the important subject in adult congenital heart disease. And I make this title just to make some a bit attractive and the when the right is wrong. So some of my colleagues were asking me in the morning, is it this is wrong in the care, wrong in the diagnosis, wrong in the I told there's something is right, but it is wrong. And basically, I'm going to speak about the systemic right ventricle circulation. And this we know those patients post atrial switch operation, TGA, post atrial switch operation, or those with congenitally corrected transposition of great arteries, the systemic ventricle is the right. So the right is and the right ventricle is in the wrong position and also is doing the wrong job. So when this happens, the normal physiology will become pathology. So, and I'm not going to speak about all the long-term complications of the this circulation. Just I'm going to touch a bit about the heart failure and systemic right ventricle and the how to approach and the recent data and publication regarding the heart failure management in those patients. So the to start with, we need to know the definition of the heart failure. And there is a universal definition and classification of heart failure. But all these, unfortunately, is applied to the normal circulation when the left ventricle is the systemic. And when it comes to the right ventricle as a systemic ventricle, there is no clear definition for those patients. So I found the definition which developed by Philip Paul Wilson 1985 maybe uh, could be applied for those patients. And he defined the heart failure as a clinical syndrome caused by abnormality of the heart. So we have abnormal heart and recognized by a characteristic patterns of hemodynamic, renal, neural, and hormonal responses. So this definition could be applied maybe for the adult with congenital heart disease and maybe for those with systemic right ventricle. The mechanisms of right ventricular dysfunction are a lot. And basically, is the right ventricle is different from the left ventricle, different from the development origin in embryology, in function, in the physiology, in the coronary supply, in the contraction patterns, AV valve attached to the ventricle, and also the papillary muscle distribution. So even in the physiology, the pressure volume lobe of the right ventricle is completely different from the left ventricle. So all these factors will lead to failure of the systemic right ventricle. So when we have the right ventricle in the systemic position, we have it was the RV is made for low pressure pulmonary circulation. So the RV will face an afterload mismatch. So very high blood vascular resistance and high blood pressure. This will lead to failure of the right ventricle. Also, there is a coronary artery mismatch with increase of the demand, with hypertrophy of the right ventricle and dilatation. There will be a tricuspid regurgitation, and this will lead to volume increase in the preload. All these will trigger the arrhythmias, and it will lead to diastolic dysfunction, and eventually it will lead to fibrosis of the right ventricular muscles and failure. So every right ventricle will fail definitely. And all those patients, if we catch them before in the stage, they may benefit from the heart transplantation. So those patients with systemic right ventricle, those with CCTGA, and those with atrial switch operation. Both of these category, there is a different anatomical variations and also different ventricular function and also different clinical presentations. So these are three patients. By the first look, the function of all these, maybe we could say is near to each other. But the first one, this is a high rank military. We just discovered him 3 years back, and he is completely asymptomatic. This patient, he was admitted with us with severe heart failure, and he is being listed for transplant. This patient has a CCTJ, fees DBS, and 5 years back he was operated by Joseph Zahrani, and he did valvular replacement, fees declosure, and physiological repair with the pacemaker. So three patients with different anatomical variation and different clinical presentation. Also, in the other hand, in the those patients with systemic right ventricle post atrial switch operation. These also three patients. This patient is 40 years. He's completely asymptomatic. This patient already transplanted last year. He was bothered with atrial arrhythmias. This patient had ventricular arrhythmias with he had ICD. Unfortunately, this patient died 2 years back. So also we have different clinical scenarios. Although by the first I inspect for those echoes, it seems like they are all the same. These two meta-analysis about those patients for a post atrial switch operation, and this was published in 2019. The other one was published in 2022. The first one, more than 29 retrospective studies plus 4 studies for ICD. The end point was to find the predictor for late mortality and prevention of sudden cardiac death. And in this study, the incidence of right ventricular dysfunction during follow-up time ranged from 7% to 98%, so very wide spectrum. The risk factor for long-term mortality in those patients with systemic right ventricle post atrial switch operation was supraventricular tachycardia, and they did not find that the right ventricular dysfunction was a predictor. On the other hand, the other study, the meta-analysis, also they studied the factors for non-sudden cardiac death or after at least 30 days following surgery. And the risk factors for long mortality in those patients, they found that functional class more than 3, heart failure hospitalization, and right ventricular dysfunction, moderate or more tricuspid regurgitation. So these two studies, and there is a contradicting finding that some of them, they said the right ventricle dysfunction is a predictor. The other, they did not find the right ventricle dysfunction is a predictor. So this give us that this topic and this substrate of disease is not well studied and not fully understood. So it needs a lot of work and a lot of trials to find the predictors and to establish a risk score for those patients. This is also two recent studies about the end stage, the end stage heart failure in CCTGA and also in atrial switch operation. These two studies done by the same group, and one published in 2023 and the other in 22. So there is more than 1,100 patients with TGA post arterial switch and more than 500 patients with CCTGA. The primary endpoint in those patients was death, transplantation, or mechanical circulatory support. In those patients with congenitally corrected transposition of great arteries, they found those patients who met the primary endpoint was those older ages who had obesity, diabetes, atrial arrhythmias, those who had ICD, impaired renal function, or those on anti-failure medication. And regarding the ventricular function, those met the primary endpoint. Majority of those patients were in the moderate to severe ventricular dysfunction, while those did not meet the primary endpoint was majority of them normal or in the mild. Regarding the tricuspid regurgitation and dysfunction and the first visit or initial visit, majority of them they will have those met the endpoint were in moderate to severe dysfunction and moderate to severe tricuspid regurgitation. And they found those patients with CCTGA usually they they will achieve the endpoint usually after the fifth decade of their life. In a multivariable Cox analysis, they found the independent predictors was the older ages, worsening right ventricle function, and the prior heart failure admission. They did not find that the anatomical complexity, history of tricuspid valve surgery, history of subpulmonic obstruction are a predictor in those patients. In the other hand, those patients with post-atrial switch operation, they found that the independent 5 years predictors for primary outcome were the prior ventricular arrhythmias, heart failure admission, complex anatomy, QRS duration more than 120 millisecond, severe right ventricular dysfunction based on echocardiography. This is the most recent study about the heart failure in patients with systemic right ventricle. This is a multi-center study with more than 500 patients, majority of them with atrial switch operation. And they try to find a score for those patients to identify those at risk of heart failure. So they found that the age above 18 years, every year with zero point 0.5, QRS duration more than 120, functional class more than 100, more than 2, atrial fibrillation, ECG, and moderate RV dysfunction or more. And they categorize those patients to high risk group. Those scored more than 23.5 those with intermediate risk between 12.5 and less than 23.5, and those low risk group less than 12.5. And we started to apply this for our patients to identify those at risk of, heart failure. Even they put a website for this one, just put it in your mobile and check these predictors, and just based on the age, QRS duration, functional class, presence of atrial fibrillation, or moderate or ventricular dysfunction, and it will give you the score and estimated cumulative risk for heart failure within the 10 years. And the higher age, the wider QRS complex, the presence of functional class more than two, the atrial fibrillation, and ventricular dysfunction, it will lead to high risk for heart failure in those patients. So this is one of the nice paper. It was published in 2019, and it touched one of the important subject and important disease in those patients, which is the pulmonary hypertension. Sometimes in those with systemic right ventricle, the pulmonary hypertension is overlooked and underestimated. But in this study, they found that it ranged between 50 to 55 in those patients. And usually those with pro-BNP, BNP more than 100, or pro-BNP more than 300 are at risk. Also, we those with ventricular dysfunction, now we are screening them with echo, and when we found normal left ventricle, rounded, normal morphology of the left ventricle in the short axis of the this indication that the LV is hypertensive, and we need to screen them with hemodynamic to make sure they don't have pulmonary hypertension. Their pulmonary hypertension, the pathophysiology for them is like the group 2 in pulmonary hypertension classification. So we need to detect them early and send them for heart transplant rather than heart and lung transplant. So when it comes to the management of the failing systemic right ventricle, there will be some the medical treatment, pacemaker or devices treatment, resynchronization, mechanical circulatory support, or eventually the transplantation. And the strategic, the management strategy in those patients is different from those patients with the adult acquired heart disease and coronary heart disease, or those with cardiomyopathy. Those for the adult acquired, they will start with neurohormonal modulation and medication, maybe the AB devices therapy, invasive hemodynamics to guide the treatment, and structural intervention. But when it comes to the adult congenital heart disease, uh, usually it will start with invasive hemodynamics to identify the cause for the right ventricular heart failure, then the intervention, then the EB devices, and at the end, the medication. So, it's completely different from the normal population. So, and regarding the medical therapy, this is one of the studies, systematic review published by the AHA-ACC guidelines in 2018. And they include six studies and more than 180 patients. And the meta-analysis assess the AC inhibitors, ARBs, beta blockers, aldosterone agonist in adults with systemic right ventricle. And the inclusion criteria was those above 18 years of age with systemic right ventricle and at least 3 months of treatment with AC inhibitor, ARBs, beta blockers, or aldosterone antagonist. The outcome includes the RV in diastolic and in systolic dimensions, right ventricular ejection fraction, functional class, and exercise capacity. Unfortunately, there was no evidence with regards to a beneficial effects of medical therapy in adults with systemic right ventricle. So it was a disappointing. This is one of the new medication, which is the Entresto, the sacubitril valsartan treatment in those patients, although it was very small sample and it was prematurely aborted because there's some of the patients withdraw from the study, and also there was some of the adverse effects in those patients. So and only six patients completed the first arm of the study, and they found that despite it was aborted prematurely, they found that there is a favorable trends regarding the primary outcome of submaximal total exercise duration and pro-BMB level. In our practice, we have few patients on who could tolerate the full dose of Entresto. Majority of them, they couldn't tolerate. So still needs a prospective study to and with a bigger sample to assess the safety and benefit. Is it beneficial in those patients or no? The other medication, which is the SGLT2 inhibitors, dapagliflozin and empagliflozin. This is also, there is small scattered studies. This is only 10 patients, and the outcome for this study was to look for the pro-BMB in those patients, and they found a significant decline in the level of the pro-BMB in those patients. In our practice, also, we found the same, and we have a good patients, number of patients on this new medication, and we are following them with the heart failure team. Regarding the cardiac resynchronization therapy in those patients, it may improve the QRS duration, functional class, and minimal increase in the ejection fraction. And the upgrade of CRT should be strongly considered in those patients with ventricular pacing and waiting for transplantation. The ventricular assist device in those patients could be a bridge therapy for transplant, but sometimes we have very limited donors, so could be a final destination therapy in some patients. So in conclusion, there is many patients with systemic right ventricle doing better than expected. So we have very wide spectrum in clinical pictures. Progressive systemic right ventricular dysfunction, prior heart failure admission, and older ages are associated with cardiovascular vascular events. Pulmonary hypertension is prevalent in those patients, and early detection is crucial. Classic medical therapy for heart failure still disappointing. It is statistically significant but clinically irrelevant. New novel medication could be promising, need more prospective randomized trial to study these new medications. Arrhythmia control, permanent pacemaker, ICD for secondary prevention, and CRT are essential in selected patients. The role of tricuspid valve surgery beneficial is controversial. It should be individualized. Ventricular assist device therapy or as could be a destination therapy or as a bridge for transplant, and the transplant is the end stage for those patients. Thank you. Patients, and it is